Um, I want to thank the organizing committee, Enrico, for inviting me. And the topic was an interesting case from Sweden. I have mentioned it as challenging the aortic arch techniques and lessons learned. But the case actually I'm going to talk about, I will say that was a case that caused us much headache before we knew the mechanism and before we had a plan how to treat it. So my disclosures. The question in this case, and keep that in mind, are we dealing with an endoleak or not? This was a 74 years old man. He had a graft replacement for an aortic arch aneurysm and also an aortic valve replacement in 1999. And he was left by the cardiac surgeons with an elephant trunk, and it was a real short elephant trunk. He was on a surveillance program with CT controls, and over time an aneurysm expanded in the proximal part of the descending aorta. And this was how it looked like when he was presented for our team. And the aneurysm measured almost 7 centimeters in diameter, and the trunk, as you see, it was short and it measured 29 millimeters in diameter. And the arch, there was a graft in the arch, and there was a diameter of 44 millimeters. So the strategy here was to do an TEVAR and use this 3 centimeter long elephant trunk for the proximal landing. That was all we had to go for. We had at that time available the new conformable gore tag, and I give you some short details of that. With the old system, you can have just one option for Stengt-Graft. For example, if you have a diameter of 31 millimeter, you see that the old system you have to stack with. You have to use a 34 millimeter Stengt-Graft, but with the new system you can choose between 34, 37, and 40 millimeter. And the good thing is that by increasing the oversizing, you can also add more radial strength. So in this case, we really wanted, as it was a short zone for fixation, we really wanted to have the maximum radial force, so we used the largest system. The gore tag, we started to implant it from below, and it deploys from the middle out to the outer end. And when we advanced the second Stengt-Graft, not by intention, but we moved the first Stengt-Graft in a proximal direction. So we had a very, very hard angulation to take care of. And we was a bit scared of how would this work, but we had, of course, to go for it. And we deployed the Stengt-Graft, and it expanded well in the elephant trunk. And we feel satisfied with that. We ballooned. We had to do a distal extension as we moved the Stengt-Graft up when we implanted the second one. So we used the new 3-low balloon. What's good with that is you don't have to play with the blood pressure, anything. 70% of the flow goes through it, and it's very rapid to inflate it and deflate it. I want to stress also that we inserted the Stengt-Graft more. If we have very tortuous anatomy, like in this case, we use the brachiofemoral through-and-through wire, and in this case we use the right brachial artery to stretch up the guide wire. The second guide wire was a Lundequist, and we took support against the valve. And this guide wire was more or less to keep the short elephant trunk in its position, so to make it easier to advance with the tag into the elephant trunk. And this was the post-operative CT. We see that the stent graft aligns very, very well to the curvature of the arch, but we see in the proximal part that there is some blood, and when we did the post-op CT, we see that there was an endoleak. And of course, we thought, our first thinking was that this was a type 1 endoleak. And this is another picture of what we thought was the type 1 endoleak. And our first, we thought of adding even more radial strength, so we thought of putting in another stent to have a better sealing in the trunk. But before that, we wanted to test our theory. So we used this tree balloon, the tree-lobe balloon, and expanded it into the in the place where the stent graft was placed in the elephant trunk. And our theory was that if we inflate that, we take away the type 1 endoleak, and the endoleak would disappear. But that was not the case. Instead, we saw even more of what we thought was an endoleak. We had inserted the balloon from an axial access, right axial access. So when we went back to the CT and turned them out and in, and then we found that actually this was not an endoleak. The blood was in a way a fistula from the old anastomosis where the graft has been sutured to the where the aortic wall had been sutured to the elephant trunk. So there was no value at all to put in another stent graft in the old stent graft. So now, what could we do here? Well, we went back to the thoracic surgeons, to the cardiac surgeons, and asked, what about a new open repair with a hybrid concept? And the first operation had been very troublesome, and they said, no, we don't want to do it. We don't want to open him once again. And even more of importance, the patient was absolutely said, no, I don't want to go through an open repair once again. So then we had to think about doing an extension, and the problem was that we measured the diameter to 45, and obviously the biggest stent graft we have in our hands is a 45. So there was really an issue for problems. But we found out that we have to go deeper into the arch, and we plan to go to the brachiocephalic trunk, and therefore we used a 45 millimeter C-tag, and before that we made extra anatomic bypass, the carotid bypass, and the left carotid subclavian bypass, and we were ready for the extension. And once again, we had to stress, take it to the bone, so to say, the C-tag with a very sharp angulation. But it worked very well. It aligned very well, but as we had expected, it was too small. So we had a type 1 endoleak. And then we had the plan B, and the plan B was to use, in this case, an embolization technique. And we used onyx to fill the space between the stent graft and the aortic arch and the arterial wall. Very important here is to have control where the onyx goes. So we had an occlusive balloon placed in the central part of the left subclavian, not to have cerebral embolization. And finally, we got rid of the endoleak. This is the completion angiography, and this is the post-op CT angiography. It's one of the problems with onyx. It's added tantalum to it, and it makes such artifacts. You cannot be quite sure if you have an endoleak or not. But we looked on the aneurysm size, and at 1 month we did this secondary intervention, and then the aneurysm stopped to grow. So I think we managed to solve the problem. And the teaching points here is that contrast in the aneurysm is not always an endoleak, and onyx can be used as an adjunctive procedure. This was the case with the headache, and now I will take a much straightforward case, but there is a point even here, and I will come to that in the end. We know for sure since many years that you can't leave a type 2 endoleak in the aortic arch. You have to, if you cover the subclavian artery, you have to put an implant plug or coils or something like that. This was a patient, 69 years old, having an open repair with the aortic arch replacement and a cabbage. And he was left, thanks God, with a long elephant trunk and an existing descending aneurysm to take care of. So the cardiac surgeons just presented him. Now you can do the rest. And this was the drawings they had did. Well, they had did a good job. They had bypassed the celiac trunk and the left carotid through one bypass, and the other bypass, which also were used for the cabbage, they have bypassed to the left subclavian artery, and they have left the long elephant trunk, but they had left the ligature, the proximal part of the subclavian, without a ligature. I don't know the reason for that. Maybe they didn't know that it's important. Maybe it was technical challenge. So this was, of course, not a big problem to solve. We solved it by using a covered Stengt-Graft and took care of the type 2 endoleak. Was very easy. So this is the post-op CT. We see the Stengt-Graft and in the thoracic, and also the Stengt-Graft at to the left subclavian. No endoleak. The teaching point here is that often catheter technique is easier than doing open anastomosis and so on. But maybe I will say that more important teaching point is that when the map change and cabbage is going deeply down, we have to watch the cardiac surgeons and what they really are doing. I didn't put it on the screen, but I think that is the most important teaching point. Thank you.